Hi everyone, just wanted to say hello and welcome to this one's e-journal committee webinar. Today we'll be discussing urine cytology in patients with gender confirmation surgery and hormone therapy and evaluation of urine cytology performance in an underserved patient population. I'm Melissa Hogan. I'm one of the e-journal committee members and the contributing author for today. And joining me is Dr. Khorsandi. He is a third-year resident and will be a future cytology fellow. He also happens to be the first author on this paper, so thank you so much for joining us today. A little bit about myself before we begin. I'm an assistant professor at Vanderbilt University Medical Center, where I sign out cytology and breast pathology. So again, today we'll be discussing this paper on urine cytology in patients. During the presentation, we'll try to monitor the chat and leave questions that we can for the end of the presentation. So the objectives today are to discuss the healthcare barriers of transgender individuals, to recognize the use of the parasystem in decreasing AUC urines, and then to determine a pattern of atypia seen in transgender individuals. And so before we would begin, I would like to discuss a few definitions for transgender and cisgender patients. So a trans man is a patient who has been assigned female sex at birth, but their gender identity lies on the masculine spectrum of gender nonconformity. And in the reverse, a trans woman is a male assigned sex at birth, but their gender identity lies on the female spectrum of gender nonconformity. The cisgender patients that we will be referring to are patients whose gender identity corresponds or aligns with the registered sex for them at birth. So a little bit of background: transgender patients, as you probably all very well know, have a lot of barriers to cancer screening and cancer care. There's limited clinician training on transgender specific screening guidelines. There's discrimination within healthcare establishments, and then barriers to accessing health insurance, as well as applying that insurance in particular scenarios. Transgender patients are at a higher risk of developing cancer compared to cis-identifying individuals. This may be possibly explained by higher levels of smoking, alcohol use, HIV, hepatitis, and HPV rates in this population. However, some transgender individuals seek medical care solely for gender-affirming care. So they're avoiding these primary care health visits and avoiding things like cancer screenings. Sometimes it is uncomfortable to go to the doctor, or the exam itself is uncomfortable, or a varying degree of other things that can occur. They also avoid healthcare maintenance related to gender incongruent organs. Again, sometimes it's due to comfortability or just access to transgender care. There are few transgender specific cancer screening recommendations, and so that leaves transgender patients to follow guidelines that have been identified for cis-identifying individuals. And so guidance for trans-identifying individuals is essentially like, if you have it, check it, right? Which means that if you have the gender reproductive organ that doesn't align with your gender identity, you would still require screening for those organs. For example, a trans man receiving a pap smear. And so again, while methodology may be the same between trans and cis individuals, there is a disparity in these screening methodologies. And again, I alluded to trans men who receive pap smears. They are actually at 10 times more likely to be inadequate for evaluation when compared with cis-identifying women. So for urines, the USPSTF has an inconclusive grade, for the recommendation of bladder cancer screening in asymptomatic adults. If symptoms concerning for bladder cancer, including hematuria or voiding symptoms, lower urinary tract symptoms in patients, urine cytology specimens can be collected by either avoided urine or instrumented urines. And then while the bladder is a sex non-specific organ, the symptoms of bladder cancer like hematuria or lower urinary tract symptoms may be interpreted by trans patients as symptoms related to reproductive organs not aligning with gender identity. And so that may put a barrier into seeking care. And this is especially concerning due to higher levels of tobacco use in trans individuals, which, as we all know, is a well-established risk factor for the development of urothelial carcinoma. So prior studies have identified a higher incidence of urinary bladder cancer among transgender individuals when compared with cisgender women, but not cisgender men. So there's a greater risk of death from urinary bladder cancer as compared to cisgender patients. And then interestingly, in the cisgender population, female gendered individuals often experience a delay in diagnosis when compared to cisgender males. This is causing bladder cancer in women to be, or females, to be diagnosed at a later stage, generating poor outcomes in bladder cancer in the cisgender population. Then delays in diagnosis in cisgender females might also contribute to the survival disparity of bladder cancer in trans individuals as well. So urine cytology in transgender patients. It's been established that there are cytomorphologic diagnostic pitfalls present in specimens gathered from patients with ileal conduits after cystectomy, for bladder cancer. Urologic complications can often be present after gender confirming surgery, or GCS, but it is unclear how these procedures actually alter the evaluation for urine cytology specimens. Presumably right after surgery, things can be extremely reactive and atypical looking, but what does that look like in the long term? So identifying any unique morphologic features in transgender patients is an important step to providing more conclusive health care. And then there is actually no literature on the utility of urine specimens in transgender patients, which is especially concerning since this is the primary screening tool for bladder cancer. So the PARA system for reporting urinary cytology, we'll refer to that as TPS for the rest of the presentation, but it's a standardized reporting system for urinary cytology specimens with clearly defined cytomorphologic diagnostic criteria. And so it leads to reported improved diagnostic performance of urinary cytology. And so per TPS, an interpretation of AUC, or atypical urothelial cells, requires exclusion of non-neoplastic changes and conditions, which is the reason for the atypia is known. And so, for example, reactive changes due to therapy are excluded from that AUC category, and such should be assigned as a negative for high-grade urothelial carcinoma. And to the best of the study's knowledge, there were no studies on the impact of the PARA system in urine cytology in transgender individuals. So for this study, they assembled a cohort of urine cytology specimens from transgendered patients for bladder cancer screening and used the PARA system to describe cytomorphologic changes in transgender patients after gender confirming surgery and or hormonal treatment. So a question for you, Dr. Khorsandi. This is quite an interesting topic. What got you interested in looking into the urines of this patient population?
Yeah, thank you. That's a great question. So I would say one of the things that I've been lucky with in my training so far at UCSF is that because they have had this very established and longstanding comprehensive transgender care clinic, throughout my training, I've gotten any number of surgical as well as cytologic specimens from transgender patients. And so in discussions with Dr. Vohra, one of my attendings and the lead researcher on this, she brought up the fact that urines in this patient population haven't been studied, and it's one, from a health equity perspective, it's a really good way for the field of cytopathology to embrace sort of the diversity that exists in the patient population, and invest sort of the time to understand how to best serve that patient population. And then because we have those patients and we have these samples, it was pretty straightforward to pull those samples and take a look at them. And then on a more personal note, I have an interest in cytopathology. So, the question of, do you want to review more urines was, yeah, absolutely. Let's look at more urines and apply the PARA system. And so I think going through the project, it was really enlightening to see how, especially like going through the literature review of what cancer care in transgender individuals looks like. It does seem as transgender individuals are able to access care more and more that literature is growing, but it is still a work in progress.
It is, and being at an institution with a comprehensive care center for trans individuals is really great because, as you said, you're able to go ahead and pull the slides, but also be part of that interactive care with those patients, helping with the comfortability, helping with the access to care, and maybe even better diagnosis because you're keeping that in mind. So thank you for that, and I'll bug you again in a little bit. So the materials and methods, 2 hospitals at a single large academic institution were searched over a 22-year time period. And then urine cytology specimens for transgender patients with a history of gender confirming surgery or hormone therapy were selected. So terms searched within the EMR were transgender, transgendered, and the remaining within that list. And then additionally, ICD-10 codes for gender identity disorders were also seen. And so, interestingly, using the term search and the ICD-10 search, I'm sure that was extremely helpful. Did you find that one of those searched terms, did a better job of indicating that patient population, or was it the ICD-10 code, or is there something else that helped you capture most of the patient population in this study group?
Yeah, that's a good question. So I would say overall, in this situation, the search terms were more useful than the ICD-10 codes. But I do think, it's important to recognize that, like, for the ICD-10 code, there's the single F64 code. And so in that way, provides a limitation to where if whoever's doing the coding is not so familiar with this specific code, if you search some of these other terms, it's not all the time that this specific code pops up as like a similar code to use. So it is easy to miss that patient population or those people who are sort of inappropriately being applied other ICD-10 codes. But then the flip side to it is, as you can see here, the search term, there are so many search terms, right? And I think it highlights that the transgender population that we're providing care for is actually a very heterogeneous population, right? So we use this umbrella term of transgender, but here you can see sort of the wide variety of terms. And it's not necessarily even an inclusive list, right? Like, this is the most inclusive that we could come up with to try and capture every patient that would fit this criteria. And so for us in this situation, I would say that the search terms were able to capture that population better. But that being said, I wouldn't sort of advise anyone to just use search terms and not use an ICD-10 10 code if you were going to do something similar, because again, the sort of heterogeneity of this population really requires like a thoughtful search of your systems.
Yeah, and I think this also, and I'll touch, I think, a little bit upon this later, helps us focus in on being more inclusive in the EMR in general, where we can capture it in the demographics information or the front page, as opposed to it being a keyword search that you hope someone typed into the chart. The other thing is the privacy of these individuals. Some folks may not come out as transgendered in front of family and things like that. And so if those people are present at appointments, it may be a little bit more non-disclosed at those appointments. So you're missing another set of patients that we could potentially go ahead and identify for studies like this. So thank you for expanding on your experience with that. So the patient demographics, indications for the urine cytology, concurrent cystoscopic findings, and the date and types of hormone therapy or gender confirming surgery for each patient were extracted from the EMR using both the clinical notes and demographic information. And then the urine cytology slides were retrieved and blinded and then reviewed using the PARIS system by a board certified cytopathologist. Interestingly, y'all noted in the paper that a lot of these were actually done before the PARIS system. And so I think a re-review under PARIS was really, really well done. All of the specimens were thin prep specimens, so one pap stain slide each, and you reviewed the all of the slides, including anything atypical. So the diagnoses utilized according to the PARA system were negative for high-grade urothelial carcinoma, atypical urothelial cells, suspicious for high-grade urothelial carcinoma, and positive for high-grade urothelial carcinoma. And then cytologic features that were noted to try to define whether or not there were specific ones associated with the transgender population were increased nuclear to cytoplasmic ratios, nuclear hyperchromasia, irregular nuclear membranes, or that chromatinic rim or nuclear border, as well as irregular chromatin, coarse or clumped. Additionally, they noted the presence of prominent nucleoli, degenerative changes with the specimen, presence of benign appearing urothelium, and the presence of cytoplasmic vacuoles were also noted. So AUC, sorry for the typo, is reserved for non-superficial, non-degenerated urothelial cells. And per the PARA system, we want that increased NC ratio greater than 0.5 and presence of only one of the following features: nuclear hyperchromasia, irregular nuclear membranes, and irregular coarse chromatin. So additionally, a control group was established with 20 additional cases from both institutions in that same time period. And they had an original diagnosis of AUC randomly identified in cisgender individuals for the comparison to that transgender cohort. So 6 of the 20 of these, which was 30%, were initially interpreted prior to the PARA system, and the remaining were interpreted after the PARA system. So these cases were also evaluated similarly to that transgender population. And then Dr. Khorsandi, how did you guys decide on 20? Did you establish your transgender cohort first? Was it just a round number? I like that they were all AUC, so you had that really solid atypical population. But I guess what gave you the inclination to do that?
Sure, yeah. So the inclination was actually from a reviewer. So we got that feedback to include a cisgender population for comparison. So then we went back, and 20 it was all pulled as a convenience sample, but as you mentioned, the intention was to capture the AUC diagnoses, as well as find a good combination of cases that were initially interpreted before implementation of the PARA system, as well as some cases that were initially interpreted after implementation of the PARA system. And then on top of that, also a mix of bladder washes, voided urines, and upper tract washings, to sort of mimic the transgender patient population that we had. And so yeah, that was sort of the intention of pulling these together.
Yeah, no, I think that's great, and it's a great comparison, as we'll talk about in a little bit. So the results, so 32 urine cytology specimens from 15 transgender patients with a history of hormone therapy and or gender confirming surgery were identified. And again, as we've been talking about, it's at this academic institution with a comprehensive clinical care dedicated to transgender patients. And so that welcoming, warm environment where folks are used to, getting the care from their specific practitioners. And so this is sort of a breakdown of the patients in urine cytology specimens. So it was 15 patients with an average age of 53, a range of 40 to 69 years old. So again, as we previously discussed, they were all thin preps. And interestingly, most of the transgender patients were male to female transitions at 87%, and 13% were female to male. The most common indication, which we all see frequently, is hematuria at 50%. And then the most common specimen type was bladder washings. There's a nice breakdown of the original cytology diagnosis and then after the review of the comprehensive PARA system. So 75% were negative prior to the TPS, and 25% were diagnosed as AUC. We did not have any, not we, but the paper did not have any that were any diagnoses above AUC. So re-review diagnosis after the PARA system, all of the AUCs were actually interpreted as negative for high grade, as we'll discuss. So again, half the indications were hematuria, and other indications that were gathered from the chart were dysuria, UTI, history of low-grade urothelial carcinoma, renal mass, frequency, and urinary urgency. So again, the bladder washings were 53%, not very closely followed by the rest. So some voided urines, catheterized urines, and some variety of washings. I found it really interesting that a majority of these specimens within the group were bladder washings and not just an initial screening voided urine. Dr. Khorsandi, I don't know if your group had any thoughts on that or if that was just happenstance, or if the screening utilization, if they have, persistent gross hematuria at your institution, if maybe they just move quickly to bladder washings. I think we may have lost you. I will go ahead and continue on, and then maybe we can discuss that point when he is able to rejoin us. So just to go over a little bit of the results, again, 32 urine cytology specimens were obtained, and 8 were originally diagnosed as AUC, 2 of which had a concurrent diagnosis of LGUN on biopsy, and then the remaining were diagnosed as negative for high grade. Reviewing the TPS, all of them were reclassified as negative. So here's, I think, a really nice table that encompasses the variety of patients and their cystoscopic findings, as well as their hormone therapy or gender confirming surgeries. So here you can see, one patient had quite a number of urine cytologies, and this was a patient that was a male to female transition, and their surgeries include a vaginoplasty. They did have a history of that 1 centimeter papillary tumor at the renal pelvis, so I would presume more frequent evaluation at that point for the patient. Additionally, some interesting things to note, again, are the indications that we have previously discussed, a variety of hematuria, UTIs, etc., and then the frequency of the original diagnoses in each patient. A lot of our gender confirming surgeries had similar procedures, including bilateral orchiectomies, scrotoplasties, penectomies, feminizing augmentations, and vaginoplasties. For the female to male transition patients, it is documented for some of them a mastectomy, and then of note there was 1 patient with more extensive surgical procedures. All right, so case review and follow-up. So again, they reviewed all of the 32 cases and also identified the presence of squamous cells in 8 of those cases. So 25%, 1 female to male trans patient and 7 male to female trans patients. Subsequent histologic findings revealed none of the patients were diagnosed with high-grade urothelial carcinoma during the period of time sampled. And so here, another nice chart. This is a chart of the 8 patients, or the 8 cases, excuse me, originally diagnosed as AUC. Again, it's encompassing 3 different patients, 2 which are a male to female transition and 1 which is a female to male transition. The indication is either the histories of low grade or hematuria, or a history of a renal mass. And so interestingly enough, most of these are actually washings of the bladder or upper urinary tracts, including the pelvis, and then the cystoscopic findings here. So other clinical history, 1 of the patients did have Hep C and syphilis, and another had chronic renal insufficiency. So just to discuss a little bit of these 3 patients with the AUCs a little bit more in depth. The first case, the patient again had a history of renal cell carcinoma, status post-chemotherapy, and this patient was a male to female patient who had vaginoplasty greater than 10 years prior to that first screening urine, and they were also on an estrogen-based injectable hormone treatment at the time of that urine collection. Cases 2 through 5 were, again, a patient with a male to female transition with a history of both vaginoplasty and mammoplasty more than 10 years prior to the collection of the urine cytology specimen. So they presented with hematuria and the 1 centimeter papillary tumor, hence the frequent evaluation of this patient. So after the follow-up of the low grade, the last 2 urines on this patient were collected during cystoscopy that actually had no significant findings. And this patient was not noted to have any history of hormone treatment documented, during or after collection. And then cases 6 through 8 were the final and third patient, which was a female to male transition patient who presented with gross hematuria and only gender affirming mastectomy. They, however, were on testosterone hormone therapy, and the cystoscopic findings identified crystals in the bladder, suggestive of nephrolithiasis, as an etiology for blood present in the urine. Was otherwise unremarkable. So all 3 from this patient were originally interpreted as AUC. So this table does a really nice job of looking at the cases as well as what was seen in each of the AUC diagnosis. And so a mildly elevated NC ratio was seen in half of the cases. Nuclear hyperchromasia was in only 2 of the cases, and cytoplasmic vacuoles are seen in 3 of the cases. More common cytologic findings included the typical ones that we think of, like irregular nuclear membranes and prominent nucleoli in 7 out of the 8 cases, and degenerative changes in 5 of the cases, which can be really challenging. The prominent nucleoli seen in 7 of the 8 cases were described as multiple small nucleoli. And of note, 7 of the cases with nucleoli were originally interpreted prior to the implementation of the pair system, and as we've been discussing, were changed to negative after. In 5 of the 8 cases, degenerative changes were identified in the presence of pycnotic nuclei and cells with stripped cytoplasm. So 7 of the 8 cases also had benign fragments of urothelium additionally present, with atypical cytologic features. So again, the re-review, although the cytologic features were listed here, they were reclassified as negative for high grade. And additionally, the 2 cases originally interpreted as L-gun were reclassified as negative as well. So the thing we all love to look at some pretty pictures. So here are some cytomorphologic features from a few of the cases that were called AUC. So here in A, we see urothelial cells with mild irregularity of the nuclear membranes. In B here, we see fragments of benign urothelial cells, and you have some overlapping and mildly disorganized nuclei. In picture C, here you can see rare cells with higher NC ratios. However, many of the cells have an NC ratio of less than that 0.5 for our cutoff for AUC. And then here, although a little bit difficult to see, we can maybe appreciate one here. There are some prominent and multiple small nucleoli within this cluster of urothelial cells, so things to definitely take note. Importantly, in this cisgender population, we want to talk about the results of that. And so 13 out of the 20 were diagnosed as AUC on re-review. 1 case was high grade on re-review, 1 case was suspicious, and 5 cases were downgraded to negative. Of note, squamous cells were also noted in 4 of the 20 cases. Dr. Khorsandi, welcome back. If you wouldn't mind, can we touch on what we were discussing previously on the bladder washings, on maybe why there was more of a predominance in this population for the evaluation of the urines that were selected?
Absolutely. Can you hear me?
Yes.
We're good. Okay, great. Fantastic. So that's a really good question. I also had a similar surprise when I looked at the data for the first time, that was how sort of it all shook out. And I will say my sort of knee-jerk reaction was, okay, maybe because of the established barriers to care, when a patient presents with any sort of urinary tract symptoms, they sort of just jump to scoping them and then taking this washing and sending it and sort of doing a full workup. As I was going through the literature, one of the things that I noticed, sort of more from the urology perspective, is that in a decent number of our patients, they've had a history of some sort of genital reassignment surgery, and post-operative complications in those surgeries are not infrequent, and that can include fistulas, that can include strictures. And so one of the sort of comprehensive ways that urinary tract complaints are worked up in patients with a history of this type of surgery is to scope them, because through that you can see, okay, here's maybe a stricture, here's a fistula, or find some other etiology for whatever the issue might be. And so I think that, I mean, I'm still sort of guessing here, and I'm not a urologist, but I think from that perspective, it makes a lot of sense that, when a patient was presenting with this and had a history of this type of surgery, they wanted to scope them, and then, as part of that process, got a washing.
I think that's a really good point, and definitely something I hadn't thought of. And I think another thing too is kind of helping streamline that care, right? So if we can try to get the answer immediately instead of getting the urine cytology, waiting, seeing, and then eventually ending up in a scope anyways, that's definitely an efficient way of taking care of the patient. And then also, sort of being really sensitive to the exam and things that can help streamline care for patients who sometimes have difficulty getting to the doctor or returning to the doctor due to comfortability. So thank you for sharing that. And then one thing that I wanted to talk about in regards to the cisgender population, and we talked about this a little bit, but were the cisgender urine controls mostly screening urines or washes? And I think we touched on that, but you can feel free to divulge again. And then given the downgrade to negatives in all of the transgender patients, the 8 samples there, were you shocked that most of the cisgendered patients stayed as AUC or less were turned back to negative?
Right. Yeah. So for the cisgender cohort, again, there was a mix of upper tract washings, voided urines, and bladder washings. But the bladder washings in that cohort intention were also sort of the more dominant type presented. And again, that was just, in an attempt to sort of mimic the transgender cohort that we had. And then, yeah, I agree with you. It was interesting. I think for me, as someone who's never learned urine cytology pre the parasystem, it was interesting to go through this experience and kind of sort of try to put yourself in the shoes of before the parasystem and having some really standardized guidelines of how you're going to interpret the specimen versus now seeing it through the lens of, okay, these are the criteria we have to meet. It was surprising to me that for the cisgender cohort, a number of the atypical stayed atypical. But I think a part of that is for the transgender cohort, there again was some explanation for the atypia, right? There was a history of surgery, or there was some acknowledgement of why these cells could be reactive or revved up or show these features that are a little funky, but ultimately still benign. And so I think that is probably one of the reasons that less in the cisgender cohort were downgraded in a sense, because I mean, maybe they have any other number of reasons that they could have been, but we didn't have that information, whereas in the transgender cohort, you have that history there.
Yeah, absolutely. I think that's a great point, especially with the patients with the gender confirming surgery, you have that reason for atypia amongst other things. But thank you so much for touching on that. So getting into the discussion, as we mentioned, 32 urine cytology specimens from 13 transgender patients were evaluated, and 8 originally diagnosed as AUC, which had a variety of features suggestive of atypia, most commonly the irregular nuclear membranes and prominent nucleoli, all were reclassified as negative. And I think it's a really important thing to think about. It's just not stones and things like that that we typically think of, but maybe some of these gender confirming surgeries that can be a reason for the atypia. Cytologic changes, I got ahead of myself, may be present secondary to reactive conditions documented in cisgender patients or secondary to the GCS or hormone therapy. Although the bladder is not a component of gender confirming surgeries, the urethra is surgically altered in both female to male and male to female transitions and could contribute to cytomorphologic changes in urine cytology specimens. On the other hand, a clinical comparison between pre and postmenopausal women revealed increased risk of bladder cancer in postmenopausal women and a significant increase in bladder cancer in women who experience menopause at an early age, suggesting that estrogen is a protective feature against bladder carcinogenesis, and reactive changes identified in this study may also be attributed to the administration of exogenous hormones in this patient population. And so while the impact of these sex steroids on the development of bladder cancer isn't fully understood, an in vivo study has shown that female mice treated with testosterone and subsequently exposed to carcinogens develop bladder cancer with similar rates, as male mice, suggesting a promotion of carcinogenesis potentially by the testosterone. So just something to think about. Given the change of diagnosis from AUC to negative, the current findings demonstrate that the parasystem improves the performance of urine cytology by lowering that rate of atypical diagnosis of the cohort of patients, which is really, I think, important because you can go ahead and decrease the follow-up if symptoms, lower urinary tract symptoms subside, or you're able to go ahead and again streamline that care for this patient population as we discussed. This reduction in AUC with a strict adherence to the parasystem is additionally highlighted in the cisgender cohort that was reviewed. So again, in that cisgender cohort, we had 7 of the 20 that were categorized as something other than AUC, and then 5 of the 7 were downgraded from AUC to negative. Okay, other considerations. Correlation with cystoscopic findings and patient history was not performed at the time of the original diagnosis. That's always a potential possibility, possibly causing mildly atypical features to be overinterpreted. As we all know and are very familiar with the parasystem, finding out those potential findings or histories can be extremely important, and not diagnosing in a vacuum, because it allows us to go ahead and have that holistic approach to the diagnosis. For example, in this patient population, clinical history of surgery or hormone therapy and negative findings on cystoscopy should, definitely prompt the pathologist to take a second look before calling something with mild atypia AUC in this case. Limitations, obviously, when we're talking about any special patient population, the number of cases presented here is limited. And this can be due to, again, improper coding, difficult searches, EMRs not being friendly for us to go ahead and find this particular patient population to go ahead and study, or lack of actual broad care in these patient populations. So again, reflecting barriers in care for accessing cancer screening. And then in addition, clinical terminology for transgender individuals is not entirely ubiquitous, so searching for them can be very difficult. These limitations, go ahead and highlight future larger multi-institutional studies needed to go ahead and continue to look at the comprehensive cancer care for our transgender individuals. So some conclusions: transgender patients are at risk for overdiagnosis of AUC and UC specimens. So reminding our trainees and ourselves to go ahead and look into that clinical history of gender confirming surgery or hormone therapy if not present for the case. Some barriers that we may face include, our requisitions may not have easy ways to go ahead and include that trans option in a drop down at a clinician's office and things like that. So changes that may result in an overdiagnosis of AUC because we don't know about these histories. And so thinking about a strict implementation of the pair system to help downgrade reactive or reparative cytologic changes in these patients can definitely help in this population. Pathologists should have a higher threshold for making a diagnosis of AUC in this population. Again, making sure we know what surgeries is extremely helpful. And then strict application of AUC can help lower the AUC rate in transgender individuals and then begin to improve that quality of cancer screening provided. Let's see. That's all I have to particularly say about the article. Just a thanks to the e-journal committee, Joanne Jenkins, and Dr. Khorsandi. Dr. Khorsandi, is there anything else that you would like to go ahead and add about the article, or maybe anything that we missed, since you're so passionate about the topic as well as I am?
Yeah, thank you. No, you did a fantastic job. I would like to thank Dr. Vohra for guiding me through this. And I think overall, and this is something you've absolutely mentioned, but just like the recognition that all of us at some point will provide care for a transgender patient, and the importance of cytopathology as a field to embrace the health equity needs of that specific patient population is really important. And I'm excited to see how that continues to grow moving forward, both as transgender patients get greater access to care, and as we invest more time and energy and resources into it.
Awesome. Well, at this point, I'll open the time up for any questions that people may have. You can put in the chat or feel free to chime in through the webcam. And if you haven't had time, oh, sorry, go ahead.
At this time, we don't have any questions.
Great, thank you. Also urge you to go ahead and take a peek at our Twitter chat from last night that you can go ahead and take a peek at with some of our hashtags that we have advertised through Twitter. So thank you again for everyone joining today. Dr. Khorsandi, thank you so much. And again, thank you for being so passionate about a very important topic. And with that, we'll say thanks, everyone.
Thank you for excellent presentation. Thank you.
Thank you.